Intraoperative hypercarbia causes and management. Causes can be first and foremost cause in a normal lung patient is hypoventilation. It's the most common cause, especially if you are mechanically ventilating the patient with inadequate respiratory volumes or respiratory rate, maybe because of low minute ventilation. Whereas in a spontaneously breathing patient, this is due to drugs like opioids, benzodiazepines, hypnotics, and inhalation agents, which all depress the ventilatory drive and cause the accumulation of CO2. And rebreathing under general anesthesia by a faulty breathing circuits or inadequate fresh gas flow in some circuit types can lead to increase in inspired CO2, which accumulates and causes an increase in the expired CO2. So the inspired CO2 itself becomes more here. FiCO2 becomes more. And the exhausted absorbed agents that also can be the culprit for these cases. The second thing is excess carbon dioxide production because with the inadequate respiratory compensation. Normally, in a healthy lung, even if the body or some pathological conditions cause excessive carbon dioxide production, we will hyperventilate and remove them. But in some conditions like severe acidosis, sepsis, cirrhosis, MH, are all where carbon dioxide is produced very acutely in a very rapid fashion, the compensation cannot be done by the respiratory system, and that is where you get a hypercarbic state. And diets which have high carbohydrates given for lung impairment can also result in hypercarbia. The third factor is exogenous carbon dioxide exposure during laparoscopic surgery and thoracoscopy, and chronic hypercarbia in the setting of lung disease. Increased dead space in any beyond physiological dead space can result in hypercarbia due to excessive minute ventilation, and this is most common in obstructive lung disease patients. However, this can be producing a normal value in capnography, thus allowing clinically significant hypercapnia going on undetected for a long time. ABG is the will show a pH in normal range. If, as you rightly said, if it is a chronic hypercapnic state, the pH will be corrected by increase in bicarbonate. Whereas in an acute stage, there is a increase in CO2 with a decrease in pH, showing that it is a purely respiratory acidosis, and even before the bicarbonate can elevate and compensate the situation, it will be an acute respiratory acidotic picture. Now, how do you evaluate that? Diagnosis is by ABG. It will show a value more than 45. And when you use capnography to approximate the PaCO2, you must always think of the arterial to end-tidal carbon dioxide gradient. However, the BPCO2 occurs more than 40 indicates that there is a chance of hypercarbia going on. And if the pH is within the normal range, it may be a mixed acid-base disorder or hypercarbia is chronic. And if the pH is less than 7.35, it indicates respiratory acidosis. And in the awake sedated patient, the patient may have dyspnea, sweating, muscle tremors, flushed skin, headache, lethargy, and confusion. And if the patient is spontaneously breathing, they always increase their rate to wash out the carbon dioxide. And if they are already intubated on mechanical ventilation, they try to come out of even if you are paralyzed, they come out of the relaxation much faster and try to override the ventilatory settings of the, say you have set the ventilator at 12, spontaneous respiration will be somewhere around 25, 26. So you will try to override the ventilator settings, and there will be always a fighting the ventilator picture. And the basic metabolic panel is for metabolic derangement detected by serum bicarbonate estimation. Is important to see whether there is a compensation or not. And workup for sepsis and fever should include complete blood count, chest imaging, and blood and sputum cultures to rule out any infection. And thyroid function test is very important because in thyrotoxicosis, you can get hypercarbia because of increased production. And in myxedema or hypothyroidism, there may be inadequate respiration, which also leads to accumulation of carbon dioxide. And in cases of head trauma, that is traumatic brain injury, there may be or an acute stress, there may be seen as this depression, which can lead to hypoventilation. Now coming to the management for unintubated spontaneously breathing patient, first choice is non-invasive positive pressure ventilation, and you must use a full face mask, not the nasal portion alone, and with bi-level positive airway pressure settings. And if the patient is intubated and not breathing, mechanical ventilation with protective ventilation, or as he said, little higher tidal volumes and increased IE ratio will help to eliminate the carbon dioxide. And rarely, in severe cases not controlled by this mechanical ventilations, extracorporeal removal of carbon dioxide may be required. So this is all what we have to write for hypercarbia. Okay. Any questions on that? Any doubts?